So our first speaker of PRECOTE is Dr. Atul Jaiswal. Dr. Atul Jaiswal is a Canadian Institute of Health Research Health System Impact postdoctoral fellow in vision science at the School of Optometry, Université de Montréal, Canada. His research aims to advance the knowledge in the field of combined vision and hearing impairment, which is generally referred as dual sensory impairment or DSI or deaf blindness. Another aim of his studies was to generate evidence to form global health and rehabilitation care practice. He obtained his PhD in rehabilitation sciences from Queen's University, where his thesis focused on identifying ways to enhance the participation of individuals with DSI in society. He received a gold medal during his master's degree in social work in disability studies. I proudly and happily share that he graduated in occupational therapy from my own institute, that is Pandit Deendayal Upadhyay, National Institute for Persons with Physical Disabilities, New Delhi, India. He has published over 25 peer-reviewed publications and presented at various national and international conferences. To build the capacity of occupational therapists and prepare them with the skills, knowledge, and aptitude to work with people with DSI effectively, we are with him, and he has already joined us from Canada. May I request him to start the session and share his expertise on occupational therapy for concurrent visual and hearing impairments, along with the physical challenge. Delegates are requested to kindly mute yourself, switch off your mobiles, and type your queries related to the topic in a question answer box in their website. Dr. Atul, please.
Hello, everyone. Thank you so much for this incredible opportunity to let me share my work here with all of you. I'm also a fellow occupational therapist like you, trained in Delhi, IPH, and Kamala sir was my teacher. It's an immense pleasure to be here today to share what I have learned so far after graduating from OT and what I have been working in the field of concurrent hearing and vision impairment. So a quick intro, I think like after finishing my occupational therapy, I went to attend Master's in Social Work and Disability Studies from Tata Institute of Social Sciences, Mumbai, and then worked for 5 years in different roles within rehabilitation organizations in Delhi and Mumbai. Before pursuing my PhD in Canada, I was working with individuals with deaf blindness, and that's what motivated me to see how I can basically take the learning from OT and social work and then do something novel so that it can improve the social participation of people who have concurrent hearing or vision loss or DSI, dual sensory impairment, in this world, which is technically designed for non-disabled population like you and me. Currently, I'm working as a postdoc fellow, trying to understand how we can improve access to healthcare and rehab adults who have dual sensory impairment in current COVID-19 institution in Canada. So it's a multi-phase study, but today it's not about the COVID-19 study. It's more about the work that I have done so far. So without any further delay, I would like to start the session. I would like to acknowledge my funders and research partners for my postdoc work, as well as I would like to thank OTICON organizers for inviting me to be here and share my work with all of you. So this is the outline of the presentation where I'll be focusing, I'll be touching on what is deaf blindness or DSI, and then I'll be touching on the aspect of deaf blindness and occupational therapy from the literature work that we know that exists on this topic. I'll also touch on the aspect of deaf blindness and research. And then finally, I'll start talking about the strategies that OTs can use. There will be some final key takeaways, and then I'll conclude. So finally, the first thing is, what is deaf blindness or dual sensory impairment? Just by the name, you can easily understand that it's all about two senses not working the way they were working initially. So, and why it is important. So I think I will touch on this aspect that 95% of what we learn is through eyes and ears. And because it is through eyes and ears, imagine that you are not able to see anymore properly, or you're not able to hear anymore properly. So how your world would be. So just to give you that context that what population we are referring to here. So it is also called dual sensory loss because it's a varying combination of hearing and vision impairment in the same individual. And it is unique and more disabling than some of its impairments. So like if you just have single sensory impairment like VI, vision impairment, or hearing impairment only, you can still compensate by using the other sense. So like suppose I have blindness or vision impairment, I will compensate by using my hearing. and vice versa. But in case of people who have this concurrent hearing and vision loss or deaf blindness, it is not possible to that extent, and that's why it results into a more unique condition. So I think it's important to set the stage with this, that first imagine how it is like to be a person who's deafblind, because Helen Keller also talked. Helen Keller was the first deafblind graduate in North America, and she was one of the most eminent deafblind advocate across the globe. So I'm quoting her, one of the quote: "Blindness separates us from things, but deafness separates us from people." And this says a lot, because I will just tease further apart the line. So it means that blindness separates us from things. So the non-living things or the living things that exist in our world, right? So if I have blindness, I don't know where I'm sitting, with whom I'm sitting close to, and what all things exist around me. So you're not getting information about the environment. And then deafness separates us from people, so living objects. So people who you like to talk to, there will be some sort of communication difficulty there. And when you bring the two things together, it becomes further complicated, that finally you will have extreme social isolation, because you're not able to interact with people whom you like to, and you like living human beings, as well as non-living things that exist around you. So I think because it's a workshop, I have some activities as well, so keep you engaging. So I think I'll just take a quick moment to think and basically make you think that what all different terminologies that you think could exist to label this current population that I'm referring to. 3 of them I already talked about. So one is deafblindness, other one is dual sensory impairment, and the third one is concurrent hearing and vision impairment. So these are 3 for sure that I just already talked about. Now, what all you think are possible terminologies that people use across the globe to talk about the same population or refer to the same population? So if you have any answers, please type in the chat box. I would be happy to see them. I'll wait for maybe 1 minute, and then I'll start again. Anything that comes to your mind would be good. So I would tell you one thing. So while I was getting my OT training as well as my social work training, I think I was also aware but not fully aware about this population. So though maybe I would have come across people like them, people like who have deaf blindness, I maybe never registered it never registered in my brain that they have deaf blindness or DSI. And because I was not aware of those, so your eyes only see what your brain knows. So because my brain was not that much aware of this population as compared to what I know now, I might have missed them a lot of times while working as an occupational therapist as well as social worker. So that's why I think I wanted to give you some time here. Okay, so now I'll move further. So I did a scoping review on the global deafblind literature to understand, it was part of my PhD work. So to understand the participation experiences of people with deafblindness in the scientific literature. So based on the work, I come across that there are 12 different terminologies that are found to be used across the globe to identify the same population. And so then you will think that, so why does it matter here that if you use 12 different terminologies across the globe to identify the same population? I'll give you a quick example. Suppose COVID-19, right? It has different names in different parts of the world. Do you think that we will be able to estimate the impact of COVID-19 across the globe? No, it will not be possible. Exactly something similar is happening with the DSI population. So people often label them as a rare or low incidence population because different names are being used across the globe to talk about the same population. So that's why it leads to lack of uniform understanding of this condition. And that's why maybe so far it has never came into the radar of our work that we have been doing in the field of rehabilitation. So the 12 different terminology that are being used here, obviously deafblindness is one of the most commonly used, because in the field of rehabilitation, I'll say education has dominated. So the field of education where children with deafblindness, like Helen Keller, they have got enormous opportunities in North America as well as in other parts of the world to learn. And similarly, in India, we have an organization called Sense International India, which is working for this population. And I was working there for 2 years before starting my PhD. So I come to know, and that's why, so we use the word deaf blindness very often, but there are other different terms that are being used, like dual sensory loss for seniors who have concurrent hearing and vision loss, dual sensory impairment by clinicians or academicians like me, and there are other terminologies that people have used also. So I think when I'm talking about deaf blindness, we need to understand it's not a homogeneous population. It's a very heterogeneous population, and that's what makes it further unique. Why we need to focus on this. So that I talked about the diverse terminology that we'll use here, and then etiology. So depending on the etiology behind the cause of deaf blindness, the manifestation of symptoms would be different. So there would be varying combination of hearing and vision impairment, and different levels of impairment would be involved based on the etiology. I'll be talking about all of these in detail in further subsequent slides. Age of onset, when the impairment is going to occur, whether it was by birth or whether it happened later on. So in my PhD work, I interviewed one person who was born okay, but then later on developed hearing loss in his young adulthood, and later on developed vision loss by the time he was 30. So imagine that you are doing everything fine till the age of maybe 10 or 12, and then suddenly you feel that you're not able to hear anymore, and then gradually you feel that in next 10 years you're not able to see anymore. So how you think the life would be? It will be very difficult, because you have seen how the non-disabled world look like, and now you have to basically live with this disability and in your further next few years of your life. Type, level, and characteristics of impairment. I'll also touch on this aspect. So there are different types of deaf blindness. I'll be talking about all of them, and then I'll showcase you that how they differ and why one intervention with one particular group will not work with other particular group. So as an OT, I think it's important to touch on all these aspects before I move further and define all of that. Modes of communication used. And this was one of the enormous learning that I came to understand while I was working in Sense India, because like normally we think that people who have deafness, they use sign language. That's one thing. People who have vision impairment, they use braille to communicate or basically read, access the information, but they have speech. In this case of deaf blindness or DSI, that as you can see in this picture as well, so Helen Keller is using a method called tadoma, where your finger and your hand is used as a mode of communication, and through the vibration of your throat and your cheek muscles, you feel. So that's how Helen Keller was communicating with her teacher, Anne Sullivan. So if you have not seen, I think you all have seen Black movie. It is all about Helen Keller, her story. But there's also original movie called Miracle Worker. So go and watch that as well. I think that will give you some little bit more context of the challenges that they have. It's very important to understand why communication is so important, like in this case. So there's a 7-38-55 rule, which means that 7% of meaning of whatever you communicate is through spoken word, only 7%. 38% is through tone of voice, and 55% through body language. So now imagine that because of vision impairment, the 38% is gone because you're not able to hear the person anymore properly. 55% is also gone because you're not able to see the person properly. So what you're left is 7% of the thing that are spoken, use with speech. And if you have hearing impairment, for sure, that is also affected. So for them, communication is the biggest challenge. And that's what the different communication modes that I'm just sort of talking about. So they use something called tactile sign language very often. But depending on the age of onset of your condition, if you have developed hearing and vision impairment later on in your life, you might have speech. And now, because of your hearing and vision impairment, that it has been affected to a certain extent, but then still you are able to speak, but not your speech is not clear anymore. So there are a lot of things. I'll be talking about all of them later on further. Types. So congenital deaf blindness and acquired deaf blindness. As per the word itself, we can clearly understand that people who are born with vision and hearing impairment, like Helen Keller, they belong to group 1, which is also called, and how do you differentiate like whether it's just born? So I think in the scientific literature, people have classified that people who are below 3 years or below the development of language, prelingual, below the age of development of language, they will basically fall into the category of congenital deaf blindness, so 0 to 3 years. Acquired deaf blindness, there are different two groups. Acquired means that they were born okay, or they were born with one particular condition, but then later on they develop another condition. So group 2 is postlingual, that after the development of language, you acquired these two conditions. Group 3 is age-related, seniors. So it's very interesting that before I landed into this sort of space of deaf blindness, even I was thinking that only group 1 and 2 exist in the world and group 3 does not. But then now I can see that group 3 also exists. Maybe our own grandparents in our own homes, they might have this condition, and I'll talk about that in soon to you. So groups within deaf blindness. So group 1, prelingual, I already talked about, those who are born deaf blind. Group 2, postlingual, after the development of language, they are either born deaf and then develop sight loss. Usher syndrome is a classical genetic syndrome that causes this particular condition, where you are born deaf or you have developed hearing impairment within the 0 to 3 age of your life, and then you develop sight loss, sight loss progressively across your adulthood stage. Group 3, age-related deaf blindness. People who are into this category, they have seen the world, right? They were non-disabled. They had no disability before they hit the age of 60, and after they hit the age of 60, they have developed hearing and sight loss. And this is a big concern because in low-income countries like India, Africa continents, and also any sort of, I'll say, South American countries, group 1 is still a big problem. And why it's a big problem? So right now, as per the current stats, we estimate, like stats of Sense International India, we estimate that there are around 500,000 children and individuals with group 1 and group 2. Because rubella immunization that was introduced in North America as well as other high-income countries way back is still not implemented very well in India. So though we have immunization happening now, but if the important piece that is important to consider here is that the immunization has to take place when the baby is conceived, and immunization should take place for the mother when the baby is inside, because that time, if the child is infected or the mother is infected with congenital rubella syndrome or rubella infection, the child will have high chances of congenital rubella syndrome, and that will lead to a child with deaf blindness. Group 3 is a big concern in high-income countries. I will show you some stats down the line, which will basically show you the picture that it's a big problem across the globe, and people still have not, I'll say, no clue what to do and how to help with these seniors who have concurrent hearing and vision loss. And because of this concurrent hearing and vision loss that they have acquired after the age of 60 because of different age-related conditions like age-related macular degeneration, cataract, diabetes, glaucoma, and hearing loss because of presbyocusis very often. And these are the aging and sensory loss is very much interlinked. That happens, and the more aged you are, like at the age of 75, almost 50% of the world population above age of 75 will have this condition of sensory, like concurrent hearing and sensory impairment. And often these individuals, like those who have concurrent hearing and vision impairment, they are labeled as having cognitive decline in most of the clinical practice, because people think that they are not able to understand what you're asking, so they will be labeled as dementia or cognitive decline. But maybe if you tease it out further, you'll see that the reason is sensory loss, not the cognitive loss. So etiology, there are different 70 conditions that are present. I already talked about Usher's syndrome. So because 70 different conditions exist, there's 70 different manifestations of this particular condition. Congenital rubella I talked about already. Low birth weight and intoxication and meningitis also can cause this. Acquired deaf blindness, Usher syndrome is a classical genetic syndrome that affects like the group 2 people who fall into the category of group 2. It's a very unique condition. I don't know whether you have come across anyone like that, but it's unique because you have seen like you're doing fine, right? But every time there's a progressive vision loss. And because of the progressive vision loss, along with the hearing loss, suppose you're sleeping, like today you're sleeping and you know that, okay, your vision is so much that you can do this much, right? Tomorrow morning when you wake up, you see there is a change. Your vision has further deteriorated. So there's always a constant change, a constant loss of vision. And because of that, it leads to a very difficult situation because whatever is working today with you may not work tomorrow. So let's talk about the numbers. So when I started my PhD, my colleagues were saying that, oh, you're going to do PhD in deaf blindness. It's such a minority population. Why are you focusing on them? And for me, it was a whole different reason why I chose, because I believe that I was the person who should do it. So because after getting a like good training of occupational therapy, social work, if I cannot do this, who will do it? So the numbers that when I was doing my PhD were around this. So 500,000 in India, 356,000 in UK, 150,000 in European Union, and 99,800 in Australia. It was always obviously thought as rare condition, low incidence population. So who cares? And then there was one study that was reported in 2017 while I was still doing my PhD. So that they estimated that this particular condition in older adults is rising, and estimated with 14.5 million people in North America will have this condition by 2036. And before I defended my work, there was a wonderful report that was out. And that gave me enough, I'll say, confidence and motivation that what I'm doing is very important. So it estimated that 2% of the world population has this condition. And when I'm saying 2%, it's quite a lot. So which means around 150 million people in the world have this condition. And in Canada, because right now I'm based out of Canada, there was another epidemiological study that was conducted, and which says that around 1 million people in Canada right now have this condition. So if you imagine the population of Canada, which is around 37 million right now, 1 million have this condition. So 1 out of 37 person is having this condition. Let's contextualize it in the context of India, 1.3 billion population. So based on my numbers, we will have around 2 crore 60 lakhs people right now in India who is having this condition. Now let's just, maybe 2 crore is sound like it is sounding too much. Even if it consider 0.2%, that's also good enough number, 26 lakhs. So I think it's important for all of us now to start thinking, and maybe first start seeing them, because once you see them, then only you know what to do with them. And hopefully my lecture today will be able to help with you all of that. So now I'll just pause for maybe 10 to 15 seconds. Let you just think over this question, that have you ever come across any individual with hearing and vision loss in your life? And when I'm saying hearing and vision loss, I will give you a spectrum. So anyone who is having low vision, or who is having visual acuity loss of more than 20 to 20/40 will fall into this category of low vision. And this range for low vision can go up to blindness, where you don't see anything, you're blind. So 20/40 to 20/200. So that's if you remember when you go and get your eye checkup, they show you the Snell's chart. So that's how you basically see where your vision is. So if you belong to the category of from low vision to blindness, and you have hearing loss of more than 26 decibel, if these two things are happening, technically you fall into this category of deaf blindness or age-related deaf blindness. Yes, if you're senior, it's age-related deaf blindness or dual sensory impairment. Whichever name you take does not matter much to me. I would rather use dual sensory impairment, or also I'll use concurrent hearing and vision impairment, because it classifies what sensory impairment we are talking about. Because often people get confused when I use the word dual sensory impairment. They think hearing and touch, hearing and taste, or other two sort of senses that we know that we all know that because we use sensory integration as well. So let's start again. So now I'll contextualize all these sort of three groups into 3 case scenarios, and then let you think about it. So now we'll present 3 case scenarios to you specific to each group 1, 2, and 3, and we'll ask you to think of challenges in their life in general. So just think, like, imagine that you are falling into this either of these category, group 1 or 2 or 3, and then how is your life, right? What are the challenging things that you do in your day-to-day life that you think are important for as a OT to consider? And also now think from the perspective of OT clinician, right? As all of we are right now. So like, if you imagine that you have a client who is coming to see you for some, let's say an example of any particular health condition, and they are coming to see you to get your OT opinion on that. And they have concurrent hearing and vision loss. How would the whole interaction look like? Do you think that you have enough confidence that you will be able to understand them properly, and then you'll be able to, I'll say, accomplish the OT goals, or the goals that you did define for them are the right ones for them? So this is again just revisiting the three groups, just to remind you of the group 1, congenital, group 2, postlingual, and group 3, age-related deaf blindness. So group 1, case 1, Sachin is a 19-year-old young adult with congenital deaf blindness. He is born with severe vision impairment and moderate hearing impairment. He lives with his family in the city of Mumbai. And now imagine that he has come to see you to receive OT services for low back pain. So do you think, now imagine your OT scenario, right? Imagine your clinic, imagine your hospital or wherever you work. Imagine that the scenario that he is now coming to see you, and now you have to start doing your OT evaluation. You have to complete the OT proforma that we all complete. So I still remember that on the OT evaluation proforma that we used, we had vision and hearing for sure in the as one of the components to look for. But I still don't remember that we were using that much detailed information about that. We were just checking whether vision is okay, checking if hearing is okay based on our subjective understanding of the person, and we were doing that. So just to give you that context. So now imagine, how would you ensure that your low back pain intervention that you plan is going to work for him if you're not able to still communicate where is the pain, what is the pain intensity level, when the pain will occur, or when the pain occurs on a normal basis. All these things are like, think of all of your questions and think of this whole interaction piece. I think that's what I want to highlight here. Case 2, group 2, there's Smita, is 35 years old, working age adult woman with acquired deaf blindness because she has Usher syndrome, and she lives with her family in rural parts of Kanyakumari. Maybe like she has come to see you because she is having difficulty in doing her household jobs like cooking and maintaining household chores because of the vision and hearing issue, right? She's 35 years old. She's married. She has baby. She lives with her family. She has her family responsibilities. How you as an OT can improve her functioning, her participation in her life. Group 3, Mohan is 79 years old, older adult. He has seen his fair amount of his life without any disability, and now he has acquired this condition after the age of 60. So he developed low vision in his 60s and developed moderate hearing loss in last few years. And now he lives in a retirement home in Bangalore. And he has come to see you because he's having difficulty in going out. Mobility is a big concern. He's having difficulty in shopping for himself because it's difficult to see and difficult to hear as well. There's difficulty in social activities. He's not able to enjoy talking to his friends in the retirement home because it's difficulty to understand what they are trying to say or also being understood. He's also having difficulty in taking medication. Like he's not sure what he's right now having he has to take 7 to 8 medications because of different health conditions that he has. And now he has to manage to get all those medicines on time. How would he sort of think of his daily life? And as an OT, we know that we are there to help with all these activities. So unique challenges of this population. So dual sensory loss leads to difficulty in engagement of person in the environment. And that's because of both the condition like vision as well as hearing. Moving around from one place to another, you're not able to see. Imagine that you're on the Delhi bus or Mumbai bus or Mumbai local train, and you have this particular condition. Establishing and maintaining interpersonal relationships. It's difficult for you to understand and being understood. It's very difficult to maintain the communication in a way that other person, non-disabled person, who is not sensitized or is not aware, right? So often they are the same people who are sitting in the party with or the marriage ceremony, but nobody is going talking to them because it's hard for both the parties to understand what is happening. Communication with the world and hinder many aspects of functioning. ADL, that is our core competency as OT. So, and all of this leads to finally experience restrictions in their participation in society. And all of these things basically make deaf blindness one of the most isolating disabilities in the world. So through my PhD work, I was able to basically tease out the aspects in form of these 5 domains: communication, mobility, functioning, social interaction, and feelings. I would encourage you to, if you have interest in this work, in this particular topic, I would encourage you to go and sort of see my participation scoping the paper, because there's a one table. I would just highlight that table to you. Just go and read that table. That's good enough to make you understand if you want to know more about this population. So I'll talk the key concepts. So for group 1, I'm going to highlight the most, because it will take a lot of time. So for group 1, it's those who are born deafblind, right? Like Helen Keller. There's always a sense of insecurity and vulnerability. Imagine that you have not seen this world, and now you're in this world where the rest of the world operates using the non-disabled principles of using things. So it's very difficult. It's very difficult for them to now develop the trust and faith in you. So if imagine that you are a occupational therapy or any clinician working with them, it first and foremost important thing would be to consider would be to develop trust with them, because until you develop trust with them, they will not work with you. And what will happen? You might often label them as autistic or maybe ADHD or any other condition, because they were not responding to what you're asking them to do, and they're having their own behaviors to basically try not to follow what you're saying. So, and maybe so whenever you're working with any kids with autism or any kids with other, I'll say, behavior issues, think whether they have any difficulty in vision and hearing, and maybe have you ruled out that as a differential diagnosis. For group 2, as I talked about earlier, that Usher syndrome, there's a progressive vision and hearing loss. And obviously the hearing loss is still manageable because of using hearing aids. If you know that you have hearing loss and you got right intervention at right time, but with vision loss, nothing could be done. So nothing could be done in terms of treatment. I'm talking about. I'm not talking about rehab that we all could do. So there's always a change happening, and because of the change, your communication needs are changing every other day. So till yesterday, you were able to manage reading books, but now maybe from today onwards, you're not able to see anymore. So the reading piece has gone, and now you are relying on Braille as a method of access to information. So that leads to a lot of psychological turmoil in your life. And that's very important for us to consider while working with them. For seniors, because they have seen fair amount of their life without any disability, and disability has stigma of disability, stigma of using hearing aids, or stigma of using any assistive device that could help. So because of all these things, conditions, they will start withdrawing. So what will happen if our grandparents, I'm not sure that maybe in your grandparents, but I have seen my grandparents, and I know my late grandmother, she had this condition. So, and it was really a bit of a challenge for us to ensure, but because I was trained, I could still help my family in India to basically make them understand what she's going through, why she's not talking to all of us anymore, because it's very hard for them to being understood and understand what others are saying. So they'll do a coping mechanism is we start withdrawing. So they'll start talking to us, and then start avoiding social contact with people outside their family as well as within family. And they are having extreme experience of social isolation. There are 2 more papers that came up from my PhD work. If you are interested to read more, you can go and see them. Developments and research. It's very interesting to see that 1904, when Helen Keller became the first deafblind graduate. And now in 2016, there's someone called Heben Girma, who became first deafblind graduate from Harvard Law School. So these are 2 important sort of landmarks for me, because almost 150 years have passed, but nothing has changed in this field in terms of research data that I'm talking about. So people have not done enough research in this field that basically makes us understand. So if you now talk about OT and deafblindness, just type this word OT and deafblindness in Google and see how many studies are popping up. There are a handful number of studies that are there because no one thought of them as an important population to start working with them. And there are other challenges also. Like now imagine that you have to conduct research with someone like Helen Keller, How would you do it? Imagine your research, whatever knowledge you have got, and now apply all of that knowledge in this context of deaf blindness. How would you conduct interviews with them? How would you conduct any sort of survey questionnaire or whatever you want to sort of use for your research? How would you do that? So basically, that's what pushed me to think that why someone is not doing research with them. And I use my PhD research to basically make a strong case that yes, regardless of the type of disability they have, regardless of the complexity of the disability that they have, we can still research with them. We can still include them in the research world, because it's very important to mainstream their voices. If their voices are not heard in this larger disability literature that we have, or rehab literature that we have, we will never think of them. So Heban Girma is talking in this picture with Obama using a technology that is one of the things that I'll be talking about. It's called refreshable braille display. I'll talk about it further. So based on my understanding so far of past 8 years of working in this field of deaf blindness or DSI, the North America green and Europe and UK, these are the only sort of countries that are right now leading this work a little bit. So in Europe, Scandinavian countries, Norway, Denmark, and Sweden, they are leading the show. In Canada, I am doing this work with my supervisor and some of his colleagues. Pretty much that's it. And in US, there is a group at Johns Hopkins University, which is leading this work. So pretty much this is what is happening. In India, I hope that I'm still sort of trying to create that momentum. I hope after this lecture is done, some of you will reach out to me and we can do something together. So, but if you see that Asia, like the Russia, Asia, Africa, we don't have enough evidence to say that yes, what we understand this population enough that we can cater to their needs in the proper way. Why do we care? We care because it's we need to generate evidence to advocate for them, to ensure that the services that we deliver are meeting their needs. We all know there are different research designs. I will not touch on these. I just wanted to have this in your mind before I further go. And this is the research process that we all use. Now imagine that you have to conduct research with these populations, the group 1, 2, or 3. Just choose either of them, or maybe think of all 3 of them. How would you go about doing this? How would you conduct the research with them to basically understand the OT needs that they have, right? So without wasting further time, I'll just quickly explain you the different challenges that people have. And that's why people like the scientific world or the researchers have never thought of this condition to be important to be considered, because there are different methodological challenges that are involved in conducting research with this population. Scientists or researchers don't know how to conduct interviews with them, how to conduct the methodology piece is not there. And that was another reason why I did this, because I wanted to get that methodology piece out in the world so that people can follow. So in my PhD, I focused on group 1 and 2 that is already published, and group 3, the seniors right now I'm focusing. So I'm conducting interviews with seniors who have concurrent hearing and vision loss, and it's very difficult. I'm using Zoom to basically interview them. It's a whole different learning process. Hopefully next year the paper will be out, and then you can read that if you're interested to learn more. So they're different. So at the level of recruitment, there are challenges. At the level of getting consent, how would you get consent? We have consent on a normal paper, right? How would you ensure that they have read all of that? And then how would you ensure that they are signing up for what they have, what they understand they're signing up for? So how would you collect the data? And how would you ensure that the data that you've collected is rich enough to tell the story? And then finally, data analysis and knowledge translation, disseminating the work that you have generated to the world. So in my PhD work, I had a little bit of answers in my mind what I could do, but I don't. I'll say that I'll be honest that I don't know all the answers when I started my PhD. Sorry. So in my PhD defense, I was asked that how would you conduct interviews with them because they're deafblind? I said that because I have worked 2 years in this field, I know a little bit about them, so I can do that. Let me try at least. So my committee members were okay with that. So there were different challenges, and I overcome most of these challenges when you can see the different strategies that I've used. So for engaging them in research, reasonable accommodations were given, interview questions, consent form, everything was given accessible format. They were given extra time to prepare the answer. So a lot of adaptations were done in this process of research to make them basically become part of this research. Obtaining informed consent, obviously providing consent forms in accessible format. I have provided consent forms in Braille as well, if it was needed. Dependency on interpreter, use of different technology, Facebook and Skype. You'll think that how could a person who is not able to see and hear could exist on Facebook or Skype? But there are a lot of people who are basically Facebook and Skype users, despite that they cannot see properly, despite that they cannot hear properly. They are using technology, and technology has changed their world as well. Difficulty in getting rich data, ensuring that different communication modes are used, and I'll quickly show you the different examples in my next subsequent slide. So out of the 16 interviews that I conducted with group 1 and 2, you can see I used different modes. And like all of these details are provided in my disability and rehab manuscript that I wrote, as well as a stage manuscript that I wrote. So you can see from this that like different modes were used. It's not like one mode, like that one particular strategy that I developed. Okay, I'll start with this will work. It was basically trial and error every time I was interviewing any new person who was deafblind because of the heterogeneity that exists. So this was published in Sales Research Methods, and if you're interested, go and read about it. Helpful strategy that we need to know as an OT. The first and foremost thing that I would highlight here are accessible formats. I will touch on these two accessible formats as the assistive technology in subsequent slides. I'll start first with training on DSI. Dual sensory impairment is a unique condition. Like the person, if you're not aware of this condition, you will never be able to identify them while you're working with them. Like imagine there are a lot of CP, cerebral palsy kids that we come across in our OT practice. Have you ever bothered to think that whether they have DSI as well? So maybe hopefully after today, you'll start seeing them. If they have CP and they have hearing and vision impairment, so it complicates the whole picture. So maybe the sensory integration or the different NDT approaches that we use have to be maybe adapted in a different way so that it fits well into this category and treats their condition. So training on DSI for all of us as well as for family members, because they need to know, because life has to be done in a different things have to be done in a different way to help them, like ADL training. So imagine that there's a person who is cooking, like she's a married lady, and she has to do all the cooking and everything, and she's having difficulty in seeing, right, when the food is cooked, when the tea is ready, but people have to do all of this. So you need to go with different simple creative ideas and how to help them so that they can still do their ADL work without getting affected or without getting harmed by the fire or anything that they're working. In terms of ADL training, you have to come up with, so basically I'll first start with saying that focus on the different things that they are right now doing, and then see how you can adapt those strategies to basically mitigate their challenges. Home adaptations, lighting, contrast sensitivity, like using different contrast background, all this will help. And optimizing residual senses. Imagine that regardless of whatever the level of disability they have some sort of residual senses. So we optimize that residual sense, whether it's touch, whether it's proprioception, whether it's vibration, optimize all those and then provide training to them. Accessible formats, Braille is one of them, large print, closed captioning that we all now know, described audio and visual information written in plain language, and accessible in electronic document. If you provide all these things in this format, pretty much most of the challenges would be taken care of. Assistive technology, this is a picture of touchable Braille display where they are trying to show that through this Braille display, whatever message you communicate. So I am still able to communicate with one of my friends back home in India. He's using WhatsApp, he's deafblind, group 1, because there's a Braille display. And then there's a closed caption television system that you can see on the left side of the picture. There was one paper like this. I'll quickly talk about the take-home message and then wind up. So every time you assess your client, ask yourself whether they have dual sense impairment. If yes, recognize and refer them to vision and hearing care professionals for assessment, because you need to know what is the level of impairment they have and how much residual senses they have. Optimize their residual senses to conduct assessment and deliver interventions. Focus on occupational performance areas that are valuable to them. I don't think you need to sort of they will tell you, but imagine that remember the 5 domains that I talked about: communication, mobility, access to information, functioning. So these are the important areas that you all think you should have in your mind while you're working with them. Provide information in accessible format. Ask them that what you could do to improve their access to information and communication, and they will tell you, because they have survived so far. They are living right now their life so far, so they know how to do, and what you need to ask that question. That's the foremost thing. As the technology could be beneficial, you need to understand when to give it and how you will introduce that to them. Taking training to develop your own skills, and working in collaboration with development specific services organizations or professionals who are working and they have expertise in this field. Conclusion: deafblindness describe people with all ages. They do not need to have complete deafness or blindness. They have some sort of useful residual hearing or vision most of the time that you can optimize. The numbers are increasing globally, so we need to start basically thinking on those lines and then understand how we can meet their needs. And research with this population is very much important, because once we have data, then only we can say that these things are working and these things are not working. The key references, and thank you so much. And if you want to know more, you want to collaborate with me to learn more and do some great work, we are doing different 6-7 projects on this topic, where I'm trying to understand how I can improve the OT and healthcare and rehab care education component so that people know about this. So I'll be happy to connect with you all over Twitter, ResearchGate, or Google Scholar. Thank you so much.
Thank you. Yeah. Any question? I can't see a single question on the chat box. Thanks a lot. I think you have done a great job, and you have really enlightened us with such a difficult topic, and which I have before also said that it's really challenging to the occupational therapist to manage dual disabilities. So I'm thankful to Dr. Atul, and I think Dr. Namrata has joined in or not. Yeah, here she is. So I'm very happy that she is also joining. Namrata, hi. So thanks a lot, Atul Ji, I should say. You have become a big man. So I'm very happy that you really finished it in time.